it didn't really feel during my undergraduate degree that I was really getting a useful skill set or set of tools until my final year when I discovered health economics. And so that kind of inspired me to go and study at University of York, where they've got a master's there. And so after that, I mean, really for well over 10 years, I was based at the University of York in the UK, which is pictured there, in some shape or form. So I worked for a few years doing health economics consultancy. So that's mainly for sort of policymakers and technology developers, so pharmaceuticals and medical device manufacturers, producing analyses for them, which they submit to policymakers. And I guess through a series of kind of a variety of different things. So I have a connection to San Diego through family, and happened to get to know someone, my now mentor, Dr. Anik Borquez, because she was previously in the UK, and you know, we developed a shared interest in research around opioid use disorder, and that kind of led me to apply for a postdoctoral position in the Division of Infectious Diseases and Global Public Health. So that's just my little pre-spiel. So today, okay, so to start with, I'm going to give a bit of a background and introduction on cost effectiveness analysis. I'm really bad at using a lot of jargon and not being too sort of sympathetic to my audience in knowing, having awareness of all the things that I'm talking about. So I thought it would be safer just to kind of try and go through in a few slides, bit of background. I'll then talk about my K01 application, which I submitted in February, and I've just about recovered from the process of writing that and submitting it. Then we'll come on to the final bit, which is hopefully kind of where there'll be some, you know, scope for discussion, which is the intersection between cost effectiveness research and implementation science. And I mean, there were loads of papers I could have chosen from, but I quite like this one because it's sort of written from the perspective of people working in implementation science. So it was interesting for me to have that as a health economist. So, okay. Just going with a definition here of cost effectiveness analysis. So this is investigations concerned with identification of practices expected to deliver value for money. And it kind of comes out of a broader background of cost benefit analysis, which when we discuss the paper, there is often a kind of a misunderstanding, or people sometimes mix cost effectiveness analysis and cost benefit analysis up. Cost benefit analysis predates you know, applications in healthcare, and it's kind of concerned solely of benefits and costs in monetary terms. Whereas in healthcare, a slightly different approach has been taken in that we're kind of concerned with benefits measured in terms of health outcomes. So the idea being that, you know, really what we're trying to achieve when we're spending money on healthcare is health improvements, or, you know, reducing health decrements as much as possible. And so, you know, you might ask, what is this value for money in healthcare? And so a kind of simple criteria for this could be a situation where we've got a new strategy that improves health while also reducing costs relative to the status quo, which, you know, that seems like a slam dunk. It's pretty straightforward. But more often than not, we're looking at something new and innovative that has the promise of delivering overall improvements in health, but at an increased cost. So particularly with pharmaceuticals and medical devices and that sort of thing. And I'll come to kind of flesh this idea out a little bit more, but basically the idea is we're wanting something that overall leads to a net improvement in population health. So just a bit of context here, this slide really, at least in terms of the tradition that I've kind of come out of in health economics, and where it kind of, what was the main driver behind research in this field. So this graph here shows per capita expenditure on pharmaceuticals. which really started to take off in the 1980s, referred to as the kind of blockbuster era of pharmaceuticals. You got a lot of, which ones were the big ones then? The proton pump inhibitors and the ones for cardiovascular diseases. It's gone out of my head, sorry. But yeah, so for sort of health insurers around the world, having these competing demands put on budgets meant that they needed some sort of a kind of explicit process for deciding which things would and wouldn't get funded, and if they were to get funded, what they would be willing to pay for them. And so this kind of this was the kind of backdrop for the like large scale application of cost effectiveness analysis from the 90s onwards. So you've got the first kind of application of this was in Canada and followed in Australia, and then in the UK in the late 90s. I'll come to talk about the US context in a couple of slides, because yeah, it's kind of a mixed picture really there. So I've been quite broad and abstract in talking about what we mean when we measure health. And obviously when we're thinking about all the different potential health areas, diseases, conditions, we can be thinking about, you know, it's almost like comparing apples and oranges. And so for policymakers who are the ones, policymakers or people who are in charge of health insurance funds, I should say that too, they need to be able to make decisions in a consistent and comparable way. And so really need a common currency for quantifying health across different diseases and accounting for mortality and morbidity. And so the health economics community came up with this tool called the Quality Adjusted Life Year. Some of you might have heard about it. I'm sorry, I'm not really going to have enough time to kind of really delve into what it means, but essentially, rather than just looking at length of life lived or length of life in a particular health state, we're adjusting it by an index that, or a weighting that reflects quality of life. And so let's suppose, and so this weighting is scored between 0 and 1, where 0 reflects a state equivalent to death, and then 1 is equivalent to full health. And yeah, as I said, I mean, there's a lot to unpack in the quality of life aspect of that. But if I spend a year in full health, so that's a quality of life equivalent to 1, that's 1 QALY. But let's say I'm spending a year in a health state that is sort of 50% of full health. That would be half a QALY. So it's allowing us to kind of have this kind of common currency in measuring health benefits. So thinking about this in terms of what the decision rules mean, this hopefully, the reason behind including all of this will make sense as we go along, because I'll kind of be referring back to this later on. But as I kind of mentioned previously, so this, I should explain this figure here first. So this figure, the y-axis is showing costs relative to status quo standard care, and then the horizontal axis is showing changes in health relative to standard care. And so standard care is represented by the intersection between the two axes. And so the kind of scenario I'd mentioned earlier, more health, in this case, more QALYs, and reduced costs. In the green here, we say new treatment should be approved. That always makes sense. And then likewise, things that cost more and have fewer health benefits should always be rejected. But the question mark really lies in these, the lower left and the upper right quadrants, which is where things get a bit more squirrely. So before I kind of go on to populate this diagram a bit more, I'll just introduce the idea of a cost effectiveness ratio. So basically this is all concerned with the marginal change in costs associated with a new strategy or a given strategy relative to standard care, divided by the health benefits in terms of you know, what that new strategy offers relative in terms of health improvements, And so we get this thing called a cost per QALY. Historically, people have talked about a cost effectiveness, so a threshold is what it often gets referred to as, of $50,000 or less per QALY. And so this number, the origins of this number are kind of a bit baffling. It's kind of the closest thing we have to an urban legend in health economics research. And I probably should set up like a Reddit forum to get to the bottom of it. But it's often attributed to the idea that in the sort of 70s, when Medicare was committing to the things it would and wouldn't fund, one of the things they would, state they would fund was end-stage renal disease. And kind of later down the line, a kind of back of the envelope calculation put that as being $50,000 per QALY. So there's a lot kind of that, it's very arbitrary, basically, is all to be said. And so more recently, there has been empirical research that's attempted to kind of quantify what the implied threshold should be based on how things are spent in the health system. And so basically this was done by a sort of simulation exercise where they looked at what happens when people lose health insurance and then what the implications are for their health outcomes. And so with this, the authors here, Vanas et al., came up with an estimate of $104,000 per QALY, which, just as a reference, it's very high. I mean, it's almost tenfold higher than the estimate we have in the UK. And I'm trying to think what might be the closest thing. Australia, maybe at about 50,000 Australian dollars per QALY. So it is very high, which is not necessarily a good thing. Depends which way you look at it. On the one hand, you might say it's good because it means that they're paying for a greater number of things. But then on the other side, because it's kind of an implied productivity of the healthcare system, it's sort of saying that the marginal gains that you're getting from a given dollar spent is a lot worse. So yeah, it's kind of good to think of that inverse point. So I mean, I've put things here in terms of the 50,000 per QALY threshold, but the idea being that kind of if you're falling below and to the right of this line, you're dealing with something that would be regarded as being cost effective. So hopefully this will be useful in kind of providing a bit of context as we go forward with things. Time-wise, I'm not going to delve into this too much, but this is just kind of my experience of things in the UK. Obviously, these things are often kind of the whole approach to cost effectiveness analysis. The driver behind it was to try and take pressure off governments and payers in making quite contentious choices. And so this kind of very scientific approach was supposed to sort of get around that issue. Unfortunately, and this is a kind of issue across the board with economics, there are value judgments involved. It's not a pure science. And so in the UK, so this is all in relation to in England, there's a body called the National Institute for Health and Care Excellence, and it makes decisions regarding the things that will and won't be covered in the NHS there. And I mean, right from its inception, it was kind of on the receiving end. It was kind of like the lightning rod for criticism and when it comes to ideas of rationing, particularly around cancer drugs. And so there's been a lot of kind of talk from the UK experience of this idea of kind of regulatory creep, where the body NICE was kind of almost forced to make concessions for their own survival. In the US, so I think it's not as easy to kind of tell a story so much about the situation in the US, because obviously you've got a kind of pluralistic healthcare system here. And where cost effectiveness in the UK and sort of Canada, Australia, it kind of plays a very front and center role, because you've pretty much broadly got sort of unified healthcare systems. So there's all the focus is going there. Whereas in the US, things kind of are done separately by different organizations and kind of done on a piecewise basis sometimes. But there are a lot of groups that are using cost effectiveness analysis to make decisions. So the examples listed there: CDC, Washington State, DOD, VA. There are some payers that are using it. And then I think in the context of this talk, as we'll come to a bit later, providers now. So specific health providers are kind of taking their own discretion in making, deciding what they will and won't pursue in terms of covering and what sort of health strategies they'll fund. A notable development in all of this is, which has been viewed with a lot of interest in the health economics community, is the development of this organization called the Institute for Clinical and Economic Review. So this is an independent, not-for-profit organization. So I think it's been kind of like bankrolled by a Texas oil tycoon or something. And it has a very similar function to the sort of organization that we have in the UK, although it's not it doesn't have a mandate in terms of the reimbursement of health technologies and things. But what tends to happen is a lot of key sort of health payers and I think where they're permitted to, even public payers, can kind of sit at the table and have a role and use that to help them inform their decisions. It's really, really interesting development because, they're not accountable from a democratic point of view, so they can kind of do what they want. So it's fascinating, honestly. And then the final point there, I think, I kind of can't talk about all of this in the US context without mentioning the fact that there's this history of resistance, the non-interference clause that was introduced, I think was in the sort of 2000s, late 2000s maybe. And, it was kind of most notably came to a head when they were trying to instigate the Affordable Care Act. And so Sarah Palin had kind of used this term of, the idea that there would be death panels deciding which kind of health care procedures and interventions would and wouldn't be covered. And I mean, the irony of this all, so kind of, in order to kind of get the Affordable Care Act through, as far as I understand, concessions had to be made. And so this kind of, the use of cost effectiveness in decision-making was kind of off the cards from a federal point of view. And it's just kind of, it's sort of ironic, that they were trying to produce an Affordable Care Act, but not even able to sort of really explicitly define what affordable means, at least at a federal level. I know that like at state levels, there are groups that are doing this sort of thing. So yeah, that's probably enough context for now. So moving on, I'll talk a little bit about my, my K application that I put in February. And so as Nicole mentioned, since joining UCSD, I've been kind of focusing on applications in opioid use disorder. And in particular, focusing on medications for opioid use disorder. So this is the standard treatment for individuals with OUD. I've mentioned two there. There are three. There's, it's gone up my brain. There's another one. If I don't write it down, I forget. But these two here, methadone and buprenorphine, are kind of the key two. And what they allow is they allow people to kind of control withdrawal symptoms that develop as a result of dependency. And there's really, really strong, robust evidence showing that this helps people improve their social functioning and their ability to do all sorts of things like hold jobs and have functional family lives and whatnot. So and also there's really good cost effectiveness evidence for this. So it's not like I need to add anything from the point of view of saying like these things are cost effective. They already are. But the kind of irony is that despite all of the good evidence, only 11% of people with OUD in the US were estimated to have received these medications in terms of the people who could benefit from it. So that is from a survey, the NSDUH. It's probably not really possible to know the exact number, but I think there's kind of a broad consensus that it's not being applied at a level that it should be. And, you know, so this is like a classic implementation problem, you know. So in kind of approaching this problem, my starting point for all of this, and I should probably add, I've got no, prior to this application and everything, I've got no background in implementation science. So I apologize, my vocabulary is going to be like very basic and stuff in relation to implementation science stuff I'm still learning. But the one thing I could hook on was I'd come across this idea of the value of implementation. So this is like an idea basically that you can put an upper bound on the cost-effective levels of implementation, of investment in implementation, if you can have information about what the sort of current and optimal levels of uptake would be. So this is kind of coming from a paper in 2009. It's listed there. So yeah, this was my starting point for things. And where did I go next with things? Well, I started thinking, okay, well, what literature is out there in terms of how we might address this? And so the 21st Century Act, Cures Act, which I think was passed in 2016, has basically kind of been pumping like billions into state targeted response grants. And so this has kind of allowed state policymakers to kind of take their own, to apply for these funds and trying to address opioid disorder in kind of innovative and new ways. And so the picture there is of a mobile healthcare service. So this is something that kind of can get around sort of transportation and sort of stigma issues, and basically home delivers people their medication. So that was in Colorado, but you know, there's been like, I think hundreds of these grants that have been rolled out across the country. So I've listed a few others there. Community outreach, so that's where they've got workers who go out into the community and try and find people and recruit them and bring them in for treatment. Because yeah, I haven't said, but the barriers to treatment are like multifold and really vary across geographical areas. So the kind of solutions that you need are pretty kind of diverse. And so sorry, my mouse isn't working here. Yeah, I should say at this point, I thought, oh, great, I've got my answer. This is what my K is going to be. I'll just focus on these things. And, you know, this is what will solve the problem. Like, I'll just try and look at the cost effectiveness of all of these different interventions. And then, you know, providers and payers can look at enacting the, you know, enacting on those recommendations, and that'll sort it out. But thank God I spoke to Professor Ahrens, because my knowledge at this stage was so basic about implementation science. And I think through speaking to him, there was just, and I know it might seem silly, but like just things that really kind of changed how I thought about everything was the fact that, you know, health systems and providers face numerous uncertainties when deciding whether to implement evidence-based practices. So kind of thinking about the kind of transportability of, when I'm talking about those new kind of innovations that have come about that we're starting to get evidence for, thinking about the transportability of those different settings. And, you know, it's not just as straightforward as saying, oh yeah, they're cost effective, we can roll them out elsewhere. But there's, you know, a whole range of other things that have to be considered. And also the fact that these risks persist throughout the implementation process. Again, this is all obvious to you, but for me, this was like my mind blown. And And so yeah, in this, it's kind of, well, I think maybe I'll come back to this in a few slides because it'll make sense, hopefully. So anyway, all of this is to say that the danger of not kind of considering these additional factors is that you can make a cost effectiveness analysis. So I often will interchangeably talk about evaluations and cost effectiveness analysis. So apologies for that, but you're going to be overly optimistic in terms of you know, your assessment of a given innovation, and to this end, you know, something that kind of I was starting to learn about was this idea that implementation costs are often irrecoverable, and so really the uncertainty for a given practice or a health provider is highest when the evidence base is least mature, and so that's, you know, like right at the beginning when they're having to first kind of scope these things out. And so the second thing was that, actually, I haven't included a point there that I was kind of hoping to have. Yeah, basically, I think while this might be the case that there is this high uncertainty, it's important to also recognize the fact that not doing anything also carries a risk. You know, even though it might be kind of a given and it would be something that kind of is happening already, cost effectiveness analysis offers a way to kind of weigh up the risks of the status quo not doing anything versus, you know, the risks of these kind of sunk costs that you end up losing if you know, implementation doesn't pan out. So it offers a nice framework for weighing those things up, and kind of building on that, because not all innovations might necessarily appear to be cost effective or affordable for a given practice or health provider. But if we look at things from like a kind of nationwide point of view, the uncertainty around the decision and the implications of collecting more evidence could be greater than just that one practice. And so there might be a rationale for like a national funder from the NIH bearing the cost because, you know, of the potential information that they would gain from that process. So this is something that's known as value of information. It's kind of already routinely used in cost effectiveness analysis. And it's where we estimate the potential benefits that could be realized from further data collection, in this case, implementation, to resolve decision uncertainty. So it's kind of, we have two separate stakeholders really. We've got the provider or health practice that are looking to decide whether to implement, but then we also have research funders. And so kind of building on this and kind of getting help and support from Professor Ahrens, kind of decided to make one of the aims of my K to focus on developing a cost effectiveness approach to inform implementation decisions for innovations for improving MOUD access and retention. And so as I mentioned before, this is kind of has a few functions. One is weighing up the risks associated with implementation against the risks of not implementation. But I think more broadly, there's like this interesting alignment, which hopefully we can maybe discuss in the discussion a bit later on, between there is an iterative approach to cost effectiveness analysis, which I referred to in talking about the value of information, where it's this idea that we if say we might recommend pursuing the implementation of something, having a feedback loop, taking the evidence that's generated when we start that process and bringing it back to inform the cost effectiveness analysis for a subsequent review. And I think, I mean, you know, I'm still getting to grips with this. There's definitely parallels in as far as like implementation science really does seem to kind of, a lot of it seems to kind of boil down to being like a dynamic process and trying to translate evidence in that sort of context. So I need to kind of take a step back just to give some additional context here to further explain what the methods that I'm proposing are. But basically, in cost effectiveness analysis, the most common vehicle for estimating cost effectiveness is through a decision modeling approach. So this is where we develop a conceptual model that kind of represents the natural history or clinical process that we're looking at with defined health states. And then using evidence to effectively kind of simulate what would happen in different states of the world if we have different strategies. And from that, we can predict long-term costs and qualities and make cost effectiveness assessments. So the reason I say all this is so I've proposed a cost effectiveness model for assessing treatments for opioid use disorder. Not specific to implementation sort of science, but more broadly. But what my proposed methodology for this specific research question is kind of incorporating parameters into that model that represent innovation and implementation costs and outcomes. And so the idea of this is by being able to characterize these things and also kind of frame things as a process with different phases. It basically, it kind of then permits this, this approach where you can review decision at each stage. So, you know, initially, okay, provider might decide, okay, we'll start to explore implementation. So that might be in a preparation phase. And based on that, based on the cost effectiveness assessments, it might seem worthwhile to pursue. And so, you know, there might be some initial research activities to look at feasibility. And then once you've done that, you can feed it back into the cost effectiveness model. And so this figure here at the bottom kind of shows how you might conceptualize the different phases within a cost effectiveness model as a kind of vehicle for decision making. And so, yeah, this is just like a representation of the process that I'm proposing. So, you know, you'd start out with a specification of an implementation decision, and that could be at any point through the implementation process. You would look to carry out a sort of review of the literature to see what evidence is currently available. We'll come to alternative methods you might use if there isn't any evidence available. Simulate the outputs from the model and then make a decision whether or not to continue implementation. And again, as I was kind of talking about before, this continued implementation could be just purely from the standpoint of the health provider, or it could be with involvement from a research funder who's looking to acquire more evidence. So I think, what if there is no evidence available in the published literature? So this is obviously going to be a really big thing. And in particular, when it comes to implementation science and kind of thinking about this transportability of evidence-based practices to new settings, where our existing evidence just might not be suitable for the setting that we're looking at. And so there's two tools in particular I've kind of identified that we might go about sort of addressing this. One is an established method, the COINS method, which was developed by Lisa Saldana. And so this is basically an approach for it's a methodology for sort of prospectively anticipating what the costs might be at different stages of implementation. And so that, at least in some way, is helping to inform decisions go forward. Okay, sorry, I just seen, oh, thank you, Erica, you'd filled in on some of my points there. Is the decision making at the provider prescriber level, at the patient level, or another level? This is really at the provider prescriber level rather than the patient level. I suppose it could be at the patient level, but I think I'm thinking a lot here in terms of when we're thinking about innovations that might involve some sort of upfront investment in infrastructure or training, that sort of thing. You know, things that are going to involve some upfront investment. So yeah, it's kind of really thinking about things on a practice level for that. I don't know whether you could really think about those things in the context of an individual patient. Yeah, so thank you for the question. Sorry, go on.
This is Nicole again. I had a sort of related question to that. Do you mind going back to the previous slide where you had the kind of decision modeling steps? Yeah, I'm just
sorry, this one here?
Yep, that one right here.
Yeah.
I was just wondering who's involved in this process. So maybe this is where you're talking about the provider, prescribers, but who else, and you, I imagine, but who else is involved in this process? Just, I need it to be concrete for me.
Yeah, no, thank you for the question and for trying to clarify that, because I haven't explained this, but I mean, as I kind of mentioned before, it could be a number of different stakeholders. My interest has been in county level sort of health departments. And then, so on the one hand, county level health departments, just because I think a lot of these sort of initiatives seem to be most effective at that level. You know, just in kind of in the context of addressing local issues and problems. But it could also be at sort of, if we're thinking more about like the level at which funding decisions get made, it could be at the state level, you know, state Medicaid, when they're deciding what they will and won't fund. I think for me, like the latter, the Medicaid state level decision making is kind of maybe more what I'd be familiar with in cost effectiveness analysis usually, but I think decisions being made at a practice level. So by that, I sort of mean, not practice level, but, you know, by like a local health department, I think is kind of more interesting just in as far as, you know, the risks are often a lot greater in terms of the economies of scale and that sort of thing in wanting to pursue something. So I think, like, I should say that my K overall really is interested in things going on at the county level. But it could be applied to kind of any kind of stakeholder who's making adoption decisions. I hope that helps.
That helps me a lot. And I don't want to backtrack more, so you can let me know if we should wait till the end, but you've used the word risk a lot. And yeah. I think as part of your first aim, you talked about sort of a comparison of risks between implementing and not implementing. Mm-hmm. I'm just wondering if you can say more about what type of risks you're trying to measure or you're thinking about.
Okay, yeah, good point. And again, this is maybe something I haven't spelled out well enough here, but I guess there are the existing risks of just not doing anything, and the risks associated with opioid disorder, people not receiving treatment are the, you know, they first and foremost, the health risks, you know, their elevated risk of overdose death. But then also a lot of kind of non-health aspects, employment, the intersections with the criminal justice system, intersections with sort of child welfare departments. You know, there's actually a long list of that. And then thinking about the risks in terms of implementation, well, this is more like the risks of it failing. You know, you might sink a whole load of money into trying to set up a new scheme, and I'm trying to think off the top. I'm not very good at thinking off my head, but, you know, an example of something like, say, that bus. You know, say the mobile treatment unit. You might spend money on you might make capital investments and personnel investments, you know, and people getting trained, and you might not realize the benefits from that. And so there are foregone resources that could have been put elsewhere, you know, by your local health department. They could have used those to some other means and realize benefits that way. And so, yeah, I think on the page that I was on the slide that I was on, I was going to talk about that a little bit more, because this is something that is the trickiest thing for me coming to implementation science is trying to think about how you go about quantifying that. because, you know, like even let's say there is a precedent of another organization that's trying to implement an evidence-based practice. That, you know, the evidence from their experience just might not be relevant if it's a rural area and the case where it's been rolled out has been in an urban area or something. And so with that in mind, sorry, I'll go back to the slide I was on. I'm thinking about where there's this kind of growing science in cost effectiveness analysis called expert elicitation. So this is where we have things that probably either are impossible to quantify or just not, you know, you wouldn't really be able to quantify them in any type of meaningful way. And I think it would be interesting to see what could happen in terms of looking at established implementation frameworks and how those might be used in conjunction with expert elicitation exercises. So this is kind of where you kind of conduct a sort of Delphi type panel survey and attempt at quantifying what the risks of implementation failure would be, or implementation success. You could frame it either way. And then also sort of the pace at which implementation might occur. So yeah, I'm still really at the kind of early stages of working out how this could be kind of realized, because you know, I don't know enough about implementation sites, but that's kind of the idea with things and thinking about the risks. So sorry, I've seen I got another comment here. Like, so this is again from Erica, like local health department's decision to set up an opioid treatment program that makes MOUD available. Yeah. So I mean, that's a good point. That, you know, some counties don't even have treatment facilities available, and you know, it might just simply be setting one of those up. And obviously, you know, there's the financial risk. So this is the thing. It's kind of, you've got on the one hand the financial risks, particularly for county level decision makers, and their kind of attitudes to risk are often very different to those at higher levels. But then on the, you know, we need to weigh those up against the health risks. So hopefully that's answered Erica's question. So Greg has asked, I really like the idea of methods to accelerate adoption and implementation of innovations. And again, it's kind of, it's how we conceptualize this or kind of characterize it in the decision modeling framework in cost effectiveness analysis, which is what I'm hopefully going to do in this K if it gets funded, is look at you know, different frameworks that are available, implementation frameworks that are available, and think about how those might be represented in the decision model, but then also how those might be used to carry out these expert elicitation exercises. So in my mind, it would be something along the lines of, you know, either getting implementation scientists to come and help, you know, do one of these Delphi panels and attempt at making, you know, predicting what the risks would be. Or people, you know, groups, organizations that have previous experience in implementation. It could be one or the other or both. But, you know, I think expert elicitation is often criticized on the grounds that, you know, it's people's beliefs, you know, and these tend to diverge quite a lot. But I mean, honestly, anytime we make an implementation decision or an adoption decision, a reimbursement decision, we're making these decisions implicitly. So we might as well try and be explicit about them and have it in some sort of transparent, you know, documented approach. So, okay, so I'll move on to the discussion paper, which, yeah, good. We've still got a bit of time to talk about this. I was worried though that I was not going to have enough time. So this paper here, looking at this kind of this issue of collaboration between health economists and implementation science. Sorry, I need to get this up on my phone. I tried printing this. I'd made some notes in a Word document prior to this, and our printers just stopped working annoyingly, so I'm gonna have to look at my phone to do this. I apologize. But yeah, basically this paper here, it kind of, in recognizing that both implementation science and health economics have important roles to play in informing decision makers. They're sort of recognizing the fact that there's a lot of potential there in terms of having the ability to affect change in healthcare practices. And so kind of against this backdrop, they conduct a qualitative study where they get a sample of health economists and a sample of implementation scientists, and try and, they conduct semi-structured interviews to kind of get some of their perspectives on this. And so I'm just going to give a quick summary of the paper just for those who maybe didn't read it, because I know that, like, whenever I go to a journal club, I'm usually just the sort of person who reads the abstract or something. I mean, from a methods point of view, I don't think it's really the focus of like interest for today's discussion, but basically what they did was they identified researchers with experience in collaborating across the two fields. And so this was done either looking at existing publications or grants. And so in doing this, they would then approach these researchers to be involved in these interviews. And then they used a snowballing sampling approach. This is where the people that you've recruited in your study, that you then ask to be involved. You ask if they know any further people who might be able to be involved in your survey. And so they got 8 individuals from each discipline. And so these in both disciplines were from a kind of range of different organizations. Some academic, there was some from the US Department of Veterans Affairs, and then also sort of policymaking settings. And so they basically carried out these interviews with an iterative process across the course of the different interviews. So they had regular meetings between interviewers to discuss notes and themes, and then kind of use that to inform future interviews that were conducted. And the questions that we're asking kind of related to the experiences with interdisciplinary research, the challenges and facilitators to this research in terms of working with the other group, and what the characteristics were of these partnerships. And I mean, one thing I found quite interesting was that one point where they did ask different questions to the two groups. So one was for the health economics one asked, what would you like non-health economists to know about your field if they hope to partner with you? And so I was thinking about that from my point of view. And yeah, I think I could probably spend hours, pages writing an answer to that one. And then the kind of equivalent question that was asked to implementation researchers, what training would be valuable for you to increase economic methodology in your implementation research? Which I don't know, maybe if anyone wants to jump in and has any thoughts on that. I see I've got another question here from Brian Garner, and they say, a tricky issue is that the payer perspective is usually key, and there are multiple payers, and they're often being a payer for the clinical innovation and a different payer for the strategies to help the clinical innovation, different payer for the strategies to help the clinical innovation be implemented. Additionally, sometimes something isn't cost effective for the payer, but there are major cost savings to other entities, e.g. criminal justice system, very tricky stuff. Brian. So you're making me regret having missed a whole load of stuff out from my application, Brian, because you touched on some really good points. And particularly, this is like so the case when it comes to opioid use disorder, as we were talking about the fact that it's very multi-sectoral. I think in a lot of health conditions, you can maybe get away with arguing that the impacts are in health domains and related to health, healthcare financing. But in opioid use disorder, it's quite different. And so I should say that the stuff that I've talked about from my research application relates to one of the research questions. There are 3 research questions. And so this is the third one that I'm talking about today, but my second one is kind of looking at how you bring different stakeholders kind of into the fray in order to make decisions, and making sure that, so there's this idea, just kind of coming to my head in response to your point there, is that the wrong pocket problem. So this is something that people talk about in economics, is where there are externalities, benefits or costs that are falling on other sectors or people, firms, and, they're not necessarily accounted for in the decision-making process. And so for this, there's kind of been a lot of work in this, in a kind of methods referred to as co-financing. So it's basically where you try in some way and reflect the cost and outcome implications for different sectors or firms or even individuals, and try and attribute those in a way that investments are made either with different contributions, although that very rarely is possible. So for example, if we were thinking about in the context of opioid use disorder, and if we were thinking about a situation where we were to say, oh, if we treat people for opioid use disorder, there'll be less crime. So police departments, pay up. We're gonna, cut your crime rates down. There's just history's kind of shown us that these sort of negotiations very rarely work out. And you kind of make the point really well here in terms of the different levels at which things might get made. There is scope, and I think there is precedent in appealing to higher levels. So for example, if you're to go to the state government and you can say, look, there are multi-sectoral things going on here. And, in that context, sometimes the kind of flows of resource allocation can be kind of more effective. Sorry, is someone just asked a question there? I thought I heard something. No, okay. Maybe someone has their microphone on then and doesn't realize it. Thank you for the point, Brian. It's a really good one, and I'm sorry I probably haven't done it any justice in responding to it, but yeah.
Thomas, this is Greg. So
hi, Greg.
I just want to say that the K doesn't have to address every single potential problem. So
Yeah.
Take a deep breath. But I think your reflections on the complexity is really something we all have to struggle with. So appreciate you taking that on to the extent that you can in this project.
Yeah, thank you. Thanks, Greg. Yeah, I mean, I'll maybe just try and zip through just because I'm wary of time on the reflections on this paper, and maybe could open things up a bit more broadly. I don't know if people would kind of prefer that, or because we've got, what, 20 minutes remaining. Is it okay if I continue talking about this paper a bit more, maybe, and then?
That's fine. That's fine.
Yeah.
Tom, you're welcome to. Yeah. Thank you for engaging in our conversations over chat, and I think people have a lot of thoughts about it and lots of questions for you. So you're doing a wonderful job, and we appreciate your flexibility and just how much content you've prepared for us.
Oh, appreciate it. Thank you. Yeah. Yeah. So I think probably might have said enough about the methods, aside from I mean, I'm really outside my wheelhouse when it comes to qualitative research, but they used a coding and theme development approach. And so in doing that, they tried to look at convergence and comparison of the different kind of codes of the text that they performed. So in terms of the results, so I think I might have included a couple slides on the results. I mean, the main headline ones were that, you know, there was a shared recognition of the common goal in trying to address real world issues. You know, and I think that's, you know, it's there with both disciplines. There's a really nice alignment there. And the second point here, which kind of really resonated with me, conducting collaborative research allowed for personal growth as researchers and improve the quality of the science they can conduct. And I have to admit, since discovering implementation science, like, and starting to, because there are, I should say, there are a lot of studies out there that are trying to get into this area of implementation science, you know, the overlap between implementation science and cost effectiveness. And it really just takes things to the next level for me. I don't know whether the same could be said for implementation scientists on the flip side, but it seems to give everything like a whole new level of meaning and stuff. And so it's been kind of like profound for me, really. And then they talk about divergence between disciplines. So implementation researchers primarily discuss partnering with health economists to conduct cost analyses. So one of the things that comes up in the paper quite a bit is this idea that on the implementation science point of view, they're very concerned about how they think about estimating costs. And then on the health economists side, them saying, well, actually, you know, cost effectiveness isn't just all about costs. There's these other things, the qualities that I was talking about, that we're also interested in quantifying. And so, you know, I think that was an interesting point. Let's see, practical issues. So I don't know whether this is like an artifact of the sample they chose, but they mentioned with a practical issue in terms of salary support for health economists, and basically the fact that they are often kind of overbooked in terms of their time, which I can't relate to, but you know, maybe it is the case. But yeah, I wonder whether they've just got like a lot of people who are like the very kind of experienced end of their CVs, careers and stuff. There was one point that I didn't agree with here, and this was that health economists noticed the importance of publishing in specific economic journals for researchers employed within traditional economics departments. So I suppose this is like the fact that some departments have, you know, they specify a preference for publishing in specific journals, but honestly, like, I don't buy that, because I mean, on the for one thing, medical journals have way higher impact factors than economics ones, so it's like, yeah, I don't really buy that. And then also, yeah, I think yeah, I don't know what to say about that beyond that, really. So the final one here, implementation researchers did identify that it would be helpful to receive training in how to lead interdisciplinary teams and increase basic understanding of health economics. So I think this is like kind of an interesting and important point. And so they refer to the fact in this paper a lot from their sample that, you know, the importance of having early engagement and what was the other one? Early engagement, and then also the nature of the collaboration. You know, it not just being people working in silos on the same project and then hoping that it'll all, you know, come together, but really having an engaged collaboration process. And, you know, I think that was like, that kind of resonated. I think this actually might be my, no, one more slide, okay. And then they've put one potential innovation could, okay, so this one is a follow-up to the previous point, where they're saying that they would see value in the creation of kind of a service that would help support economic evaluations within implementation research, including the measurement of implementation costs. And there are some precedents with that in terms of health economics services, and they even refer to the Cherish group, which kind of basically for people who are involved in either grant applications or in publishing work, going for kind of, you know, technical expertise and input. And yeah, I wasn't aware of this group in working for the VA. So I'm just worried because we've got 15 minutes left to give people a chance to ask questions and stuff. So I might just kind of stop things there and open things up if people have any questions. I should say I also have more stuff to talk about, but I did kind of rush through the discussion of the paper there. So, but I don't know, I think it'd be interesting to hear, like, if anyone did read it, what their thoughts were, or if you have had experiences working, you know, in this kind of pocket where of where health economics and implementation science meets.
Yeah, Thomas, Greg again, and thanks for all the stuff you presented. Lots to talk about. I think in terms of this article, David Sommerfeld, who's also on today, we had reached out a number of years ago to a health economist in the Department of Economics, and we heard that same thing. Oh, I have to publish in the economic journals. So I think part of it is a function of, you know, where you're located. So you're in the School of Medicine, in infectious disease, and so probably you would be evaluated more on the, you know, well, number of publications and all that, but also like impact factors and reach for the field in terms of health sciences, versus if you're in a Department of Economics, they're going to look for publications in those journals, just like our colleagues who are in schools of business or industrial organizational psychology. There's sort of those set outlets. And I think that's just, you know, something that we all have to think about in terms of strategy, in terms of our publication and what audiences we want to reach. But, you know, there may be some where the content, you know, you would want, or maybe it's very technical and it would go to an economic journal versus something more applied in terms of implementation and public health impact, which could go to a journal like Implementation Science or Frontiers in Health or something like that. I don't know what others think, but I think it's a bit of an artifact.
I mean, if there's no one else, I mean, just to kind of respond to that point, now that I'm thinking about it, I should say the fact that within health economics as a discipline, there are actually kind of a few sort of different strands of research within health economics, of which kind of cost effectiveness is a big part, but there are kind of a lot of other, a lot of other strands concerned with things like performance measurement and what we call econometrics. And I think, okay, they people in those disciplines are almost always likely to be in an economics department and concerned with publishing in economics journals. And yeah, maybe because those types of researchers also do sometimes dip their toe into cost effectiveness research. I think a lot of the time though, honestly, like if someone is committed to cost effectiveness research, they probably might already be in a medical department. I don't know whether that's an unfair statement to make, but yeah, that's just my take on it. Yeah.
I think that this is Dave Sommerfeld. I work with Greg Ahrens and others at UCSD, and I think this bumps into some things that we also encounter in certain fields where, especially if you're working with like local health departments, their priority isn't necessarily publication. And so I'm trying to get kind of matching the technical assistance needs of doing these analyses and really understanding the cost implications. You have to get the right circumstances to align that it is something that they're open to being more generalizable research and be able to publish. But I think there's a huge demand. I think this came through in the findings in the paper on the implementation side. It's like we want lots of economists to help us understand how to compute costs and communicate cost issues to all sorts of decision makers. But that isn't always necessarily aligned with a publishable product. And so that diminishes the pool of individuals that are ready to partner at some level.
Yeah, I mean, that's interesting. So, I mean, I suppose like in one sense, like in terms of research collaborations and having research teams, I do wonder whether sometimes if you have groups that are kind of clustered more in terms of a shared interest of a particular sort of health area or disease, whether that might be more conducive really to having different experts rather than, you know, someone who works purely in kind of health economics department. You know, that then things become a bit more siloed. Sorry, we've got another comment here from Nicole. A follow-up debate paper where we offer a team science model to build capacity for economic evaluations, and I'll be sure to look that one up. Thank you, Nicole. Yeah, I think you know, there were a few interesting things that came out in the paper, and as far as, you know, there was mention of the fact that people talking in different languages, so to speak, you know, and trying to navigate that, and, you know, even if you can navigate that with I don't know, some sort of like cultural broker or something who knows both sets of languages. Like, I think sometimes, and they kind of raise this point, that it helps to have some background. And, you know, as I'd mentioned, like for me, before approaching implementation science, it was like I was very basic and one-dimensional in what I thought it meant. And it took reading, you know, at least a couple of papers to even start getting my head around things. And but it's difficult when, you know, there are lots of, you know, we're encouraged to be you know, multidisciplinary in so many different ways, and you know, it's like then you've got to think about all the other potential fields that you have to be aware of.
That's interesting, Thomas. I think this quote about the query that conducts implementation research has a dedicated group of health economists, but we really don't see much in the literature coming from that group. It's like, yeah, they provide consultation, but how much really comes out? So, you know, I'll just say this, we're very excited that you're interested in implementation research, and we are rooting for your K because we want you to be here helping us. So
that's cool. Thank you. Yeah, I mean, I think I should say that one group that they refer to, I don't know anything about the VA one, if I'm honest, but the Cherish group, I think their priorities really are more consultation when it comes to substance use disorders. But there is a group in Canada, Simon Fraser University, and there's a guy there who is actually a collaborator on my K called Boda Nosic, and he's had a few NIH awards looking at implementation science in this sort of context, and yeah, I think he's like very, very engaged and really wanting to kind of you know, look at how these two fields can kind of come together to produce something new in a way. Yeah. Yeah, so thank you, Erica, for clearing that one up. Erica